a language nobody taught you in medical school. In 1966, the American Medical Association published for the first time a standardized catalog of medical services. They called it Current Procedural Terminology, CPT. The goal was straightforward: create a common language so that physicians, hospitals, insurers, and government payers could all refer to the same service using the same numerical code. No ambiguity, no negotiation over what was done, just a 5-digit number that described it. By 1983, CPT was formally adopted by the Centers for Medicare and Medicaid Services as the national standard for physician billing, and by 2000, it became the legally mandated coding language for all medical services in the United States. Every claim, every visit, every procedure translated into numbers. Now, here is the part no one tells you when you graduate. This language, this entire second vocabulary of medicine, is not taught in medical school, not in residency, not in fellowship. You will learn anatomy, physiology, pharmacology, and psychopathology. You will not learn how to translate a 45-minute medication management visit with a complex patient into a defensible billing code. You will have to figure that out yourself, usually at midnight after a 12-hour shift, with a denial letter in front of you. And the stakes are not trivial. Miscoding is not just a revenue problem. It can constitute fraud, it can trigger audits, it can cost you your license, and yet the system expects you to master it on the fly, in your spare time, while running a clinical practice. The good news, and there is good news, is that the codes were invented by us, by clinicians. The AMA's CPT editorial panel has 17 members, the majority of them physicians nominated by medical specialty societies. This is our vocabulary. We wrote it. The problem is what happens to it once insurers get their hands on it. How insurers corrupt a language they didn't write. Once a CPT code goes from the AMA's codebook into an insurer's claims processing system, it enters a very different world. The code doesn't change, but everything around it does. Let me walk you through the most common strategies used to deny or reduce payment, because your documentation needs to be written with these tactics specifically in mind. The first category is denial based on clinical judgment. This is the one that infuriates physicians the most, because it directly contradicts the treating clinician's expertise. Medical necessity denial. The insurer decides, using their internal guidelines, not yours, not the DSM, not the literature, that the treatment is not warranted. You prescribed it. They overrule you. Experimental or investigational labeling. A newer therapy is cherry-picked against an isolated study and called unproven, while the weight of clinical evidence is ignored. Step therapy or fail-first protocols. The patient must fail on a cheaper drug before the insurer will approve the one you actually want to use. Clinically irrational, bureaucratically convenient, downplaying severity. A physician employed by the insurer, who has never met your patient, reviews the chart and concludes the illness is not severe enough to justify the level of care you billed. The second category is downcoding and payment reduction. Here, the claim is technically accepted but paid at a lower rate. Algorithmic downcoding. AI software scans the claim and automatically drops a level 5 complex visit to a level 3 routine visit based on diagnosis codes or patient demographics, without a human being ever reading the actual notes. Diagnosis-based code reduction. A diabetic patient's visit gets automatically paid at a lower rate because it's classified as routine care, regardless of what actually happened in that room. Prepayment reviews. Certain providers or diagnoses are flagged for mandatory audit before a single dollar is released. A fishing expedition by design. The third category is administrative attrition, making the process so exhausting that you give up. Delay, deny, defend, the 3 Ds. Stall the investigation, reject coverage without proper review, force the provider or patient to litigate. This is a documented and systematic strategy. Excessive documentation requests. Repeat requests for records that have nothing to do with adjudicating the claim. Death by paperwork. Lowball settlements. Offer something small, fast, before the full cost of care is known. And finally, the technical and contractual denials. Prior authorization failures. Coverage is denied because pre-approval wasn't obtained, even if the treatment was urgent and medically necessary. Filing deadline violations. A claim submitted 1 day late is dead, regardless of merit. Out-of-network and eligibility disputes. The patient's coverage lapsed on the exact date of service. Coincidental, consistently. I am not telling you this to demoralize you. I am telling you this because your clinical documentation is your first and most powerful line of defense against every single one of these strategies. Write the note for the auditor, not just for the next clinician. Make it harder for a software algorithm to misclassify what you did. Now, let's get to the main subject, which is specifically about psychiatric billing and the critical distinction between two categories of service, the medical psychiatric component and the psychotherapy component. As I have discussed in previous presentations, psychiatric treatment has 5 pillars: medication, psychotherapy, physical exercise, normalization of sleep, and a composite of social structure, structured daily routine, purpose, and social support. Today we are only concerned with the first two because they generate different CPT codes, they are reimbursed differently, and confusing them in your documentation is an invitation to a denial. Here is how the CPT system formally separates them. Pure psychotherapy, without any medical evaluation and management, is coded as 90832, 90834, or 90837, depending on time. When a psychiatrist or nurse practitioner performs both medical evaluation and management and psychotherapy in the same encounter, the medical component is coded with standard E/M codes 99213 through 99215 for established patients, and the psychotherapy is added as an add-on code 90833 for 30 minutes, 90836 for 45 minutes, 90838 for 60 minutes. The two services must be, as CMS itself states, significant and separately identifiable. That phrase is doing a lot of legal work. It means your documentation must demonstrate that you actually provided both services and that each is clearly described. What counts as psychiatric medical service? So, what exactly qualifies as the medical component? The medical portion of a psychiatric encounter is the intellectual and clinical work that is specifically about the illness as a biomedical entity. It includes the following: discussion of the diagnosis, the nature of the illness, its neurobiological and biochemical substrate, the electrophysiological disturbances underlying the symptoms. Symptom review, what is present, what has changed, how the symptom profile compares to baseline. Natural history of the illness, how it evolves with treatment versus without, what the long-term trajectory looks like, what relapse risk looks like. Medication rationale, why one molecule was chosen over another, what the mechanism of action is, what receptor targets are involved, what the pharmacokinetic profile means clinically. Side effect counseling, anticipated adverse effects, their timeline, their management, when to call. Benefit timeline, when to expect a response, what a partial response looks like, how to distinguish therapeutic effect from placebo effect. Substance use discussion, the impact of alcohol, cannabis, street drugs, and non-prescribed psychoactive substances on the illness and on medication efficacy. This is especially important when there is a current, recent, or severe past history of such use. Medication compliance, the importance of consistent adherence, and the practical strategies to achieve it. On that last point, let me be specific, because insurers love to deny visits as non-medical when they were actually spent on the entirely legitimate medical topic of medication adherence. Strategies that qualify as medical discussion of compliance include pairing medication with a stable daily habit such as morning coffee or toothbrushing, using pill organizers, weekly or monthly, setting phone alarms or reminders, using smartphone apps designed for medication tracking, keeping medications in high visibility, high traffic locations in the home. These are not lifestyle suggestions. These are clinical interventions targeting a core problem in pharmacological treatment, non-adherence, which is one of the leading causes of relapse and treatment failure in psychiatric illness. Document them as such. Now, what counts as psychotherapy? Now, the second service. Psychotherapy is not simply talking about feelings. It has a specific clinical architecture, and your documentation needs to reflect that architecture if you want the add-on code to survive scrutiny. The first prerequisite is definitional. Psychotherapy is everything that does not meet the definition of psychiatric medical service, but it must also be something specific. It must be focused on the patient's emotional experience, the affective state, its intensity, its duration, and its drivers. In practice, a psychotherapy component will typically involve the following sequence of work: identifying and naming the emotional state. What is the patient feeling? Is it sadness, anxiety, shame, rage, hopelessness? This is not a trivial exercise. Many patients, especially those with alexithymia or years of avoidance, cannot name their affective states without clinical assistance. Tracing the emotional state to its trigger, the events, circumstances, or interpersonal dynamics that precipitated this mood. Not the facts of what happened, but the patient's interpretation of those facts. What meaning did they attach to this sequence of events? What assumptions did they make? What narrative did they construct? This is the cognitive substrate of the affect, and it is where CBT, psychodynamic, and virtually every evidence-based therapy does its work, appraising the emotional reaction on three axes: type, intensity, and duration. Is the emotional response congruent with the situation? That is the first question, but equally important and far less obvious. Is the intensity proportionate? Is the duration appropriate? A grief response that is appropriate in type can still be pathological if it is disproportionately intense, or if it persists for months when the situation no longer warrants it. These three axes, type, intensity, duration, are the clinical coordinates of affective pathology, exploring behavioral response options. Once the emotional state and its cognitive underpinnings are mapped, the work moves to behavior. What did the patient do, or what are they considering doing? Did they withdraw, acquiesce, comply to avoid conflict? Or are they prepared to take a more active corrective stance? When active coping is the goal, the psychotherapy explicitly involves imagining and defining a desired outcome, identifying the means to achieve it, and beginning to implement a strategy. This is directive, goal-oriented psychotherapy, and it is a distinct clinical service. Notice how different this is from the medical component. The medical component discusses the illness. The psychotherapy component engages the patient's subjective experience, their interpretive framework, their emotional responses, and their behavioral choices. These are not the same thing. They require different clinical skills. They produce different clinical outcomes, and the CPT system correctly distinguishes between them. So how does this translate into documentation practice? Practically speaking, your combined visit note needs to contain two clearly distinguishable narrative threads. The medical thread documents what symptoms were reviewed, what medication adjustments were made and why, what was discussed about mechanism or side effects or compliance, and what the clinical reasoning was behind any decision. This section should read like a medical chart note because it is one. The psychotherapy thread documents what emotional state was identified, what cognitive or interpersonal material was explored, what therapeutic technique was applied, whether cognitive restructuring, behavioral activation, motivational interviewing, or supportive work, and what progress or new understanding emerged. This section should demonstrate that a clinically structured psychological intervention occurred, not just a supportive conversation. When an insurer's algorithm tries to downcode your level 5 visit to a level 3, it looks for certain markers of complexity. When it tries to strip the psychotherapy add-on code, it looks for evidence that the psychotherapy component was distinct, time-delimited, and clinically substantive. Your documentation is the evidence. Write it as if you are already in the appeal. And if you are in a large institution where professional coders handle your claims, do not assume you are insulated. You still need to understand this system because the coder can only code what you document. If the psychotherapy is real but invisible in your notes, you will be billed at a lower level. The revenue loss is yours. The liability is yours. The knowledge has to be yours. The CPT system is our vocabulary. We built it. The AMA's editorial panel, composed of physicians, maintains it, updates it, and publishes it every year. It is a codified acknowledgement that psychiatric work is medically complex, that a pharmacological management visit is not the same as a psychotherapy session, and that doing both in the same hour is worth more than doing either alone. The insurers know this. That is why they invented algorithmic downcoding. That is why they have humans reviewing charts and arguing that your schizophrenic patient on 4 medications with a history of 3 hospitalizations does not require a high-complexity visit. That is why they built prior authorization, step therapy, and every administrative friction device in their arsenal to erode the granularity of our coding system until all visits look the same and all visits pay the same. Our answer is documentation. A rigorous, specific, clinically grounded documentation that makes the distinction between medical and psychotherapeutic service unmistakably clear. That translates the reality of what happened in that room into language that survives an audit, survives an appeal, and survives whatever the next generation of denial software throws at it. Learn the codes, not because billing is why you went into medicine, but because the quality of your patient's care depends, in part, on whether you get paid for it.